சாந்தியும் சமாதானமும் உண்டாவதாக. Ladies and gentlemen, when you go to a general practitioner with headache or giddiness, so routine examination, he or she checks up your BP. The first sitting, if it is elevated, the general practitioner will not disclose this. After some suggestion to modify your lifestyle and eating habits, etc. Again, you will be asked to come for a recheck-up. Second time, the BP is checked up. Third time, the BP is checked up. Sometimes, 5 times, they check up the BP. And if the average is higher than normal, the doctor is cautioning you about elevated blood pressure. But you will be surprised that no symptom is there. No persistent symptom is there. For simple transient headache or giddiness, doctor is dumping you as a high BP patient to advise you to be on long-term treatment. So we may not like it. The problem is this type of patients, asymptomatic hypertensives with potential end organ damage, that will be a silent killer. So we have to target on these type of patients and start or think about the strategies to manage this type of patients. When a doctor is finding out your patient is hypertensive, he orders a battery of investigations. Whereas a non-allopathic doctor like Ayurvedic, Unani or homeopathy fellow, after checking the BP, he just prescribes some drugs like what we do and leave the patient. Whereas allopathy doctor, he orders head-to-foot investigations. Why? One potential mechanism for persistent BP is that increased cardiac output. That is called, high output hypertension. This is called pump-based hypertension. For the BP, contributing factors will be increased cardiac output, increased heart rate, and increased peripheral vascular resistance. So these type of patients, increased cardiac output will be there, and their normal and their systemic vascular resistance will be normal. Most often this type of pump-based hypertension is seen in young individuals. So the beta blockers will be very attractive for this type of pump-based hypertension. And number 2 is that vascular resistance-based hypertension. With people, geriatric people like me, very common in elderly people like me. That is occurring because of the disparity between local vasodilatory factors like nitrous oxide and constrictive factors, endothelial factors, endothelial damage, dysfunction, thickening, all these things are there. Because of the disparity between these two, this increased vascular resistance occurs. Here the cardiac output may be normal. So here the modality for the management is that first preference is thiazides, thiazide diuretics. See, in diuretic dosage, they decrease the volume by excreting lot of sodium and water, thereby decreasing the load, cardiac output. Intravascular volume is decreased in diuretic dose, but not in the diuretic dose, but in the very minimal dosage. It has been found to be having vasodilatory effect. So this is the drug of choice in this type of that is peripheral vascular resistance based hypertension. The third thing is that very important thing is that renal function. That is volume-based hypertension. So it can be renal parenchymal disease or renal vascular disease, where there is decreased perfusion, which stimulates the beta cells of the juxtaglomerular apparatus, and renin secretion is increased, which produces increased amount of angiotensin II and increased amount of secretion of aldosterone, which will increase the sodium retention and water retention. That in turn will increase the cardiac output and heart rate, ultimately results in hypertension. So these type of hypertension, the renal cause is there, extrarenal cause also may be there. Sometimes a tumor may be pressing the renal vasculatures and producing ischemia. Renal artery stenosis will be there, unilateral and bilateral. So many reasons are there pertaining to renal causes. And fourth important thing is that neuroendocrine function. Central sympathetic outflow, for some reason, if it is increased, hypertension will be there. Or in the periphery where there is endocrine dysfunction is there. For example, suprarenal glands, hyperplasia, that is pheochromocytoma, or primary aldosteronism, or hyperthyroidism. In all these conditions, that is secondary hypertension will be there, where a physician has to look in for primary cause and treat the cause with antihypertensive drugs. So, ladies and gentlemen, my dear friends, if this my talk is a little bit of use to you, just give me your feedback. I will continue in future with the holistic approach in the management of hypertension. Thank you very much. Thank you.